Thank you so much.
All right, let's go ahead and get Grand Round started. Today we're really happy to have a guest speaker here. Dr. Albert Park. Dr. Park is the Chief of Pediatric Otolaryngology at the University of Utah. And we know him through the fact that we're working with him on an NIH project. He's the PI of a multi-centered NIH-sponsored project to look at newborn screening for cCMV. We're evolving an understanding of what might be beneficial for children for management of cCMV. He's one of the leaders in figuring out how we might take current knowledge and bring it forward to help us understand how to apply what we know in the future to build a greater approach to handle effectively children who have cCMV. So we're very happy to have him here. He's on a tour through Louisiana. It's his first trip to Louisiana. We got some Cajun food at Maryland's last night, so I think he's well oriented to our place. And we'll look forward to the presentation. So, Mark, thank you for coming. Thank
you. So, good morning, everybody. Hopefully you can hear me. There's just a little construction going on. So yes, it's quite an honor, Dr. Bertini. Thanks for having me here, and a great introduction. And I am going through a little tour of Louisiana, and have really enjoyed the terrain and the tradition and the hospitality here. And so really enjoying our time here. But I did want to talk a little about this condition, which I think is unfortunately somewhat not very well understood, and I think I wanted to bring to your attention what I think is a very devastating disease and process. Let me see if I can get this to work. So in terms of non-disclosure, I do have some NIH grants. I'm a principal investigator for a multi-institutional study, as mentioned earlier, and I'll talk a little bit about that shortly. As also a co-investigator on a cochlear implant in a novel PE tube design study, and I will be talking a little bit about valganciclovir, which is not FDA approved for treatment for congenitally infected children, but I did want to share with you some of the evidence in this modality. And then I am, just to disclose, a consultant for Merck and for Roche. So I have three objectives that I want to bring to your attention, which I think hopefully I'll be able to satisfy. And the first one is to convince you that congenital cCMV infection is a very important condition that we all need to know about, not only as clinicians, but if you're a brother or sister, if you're a grandparent, if you're a father or mother, this is a condition that very likely may affect your family. And when it does, it can be very devastating. I also want to discuss with you the rationale for congenital cCMV screening. I just heard that this institution has implemented it recently, and I congratulate you for your efforts. And I want to kind of share with you the rationale as well as our experience collectively in the Valier trial. I'm part of a site study of over 25 institutions, and so I think over the last 6 months to years, we've developed some important insights about the screening process. And so I will share with you a little bit about how, for those institutions that haven't started screening, what sort of components I think are very important for the success for these programs. Now to start, I want to share with you a video. This is from Caitlin Hill. Her mother here is going to talk a little about her experience with congenital cCMV infection, and I think it really brings home, at least to me, why this is such an important condition.
It was so easy.
A couple of ultrasounds before Caitlin was born, there were things happening medically, with ultrasounds that made us nervous.
And I just assumed when they said, well, we've got this problem, but this one cleared up, that it really wasn't that big of a deal.
I always felt a little bit left down in that way, that we didn't have a whole lot of information. Nobody said, hey, this is actually a big deal. Your baby could be in danger. I don't know if they wanted to protect our feelings or what, but it seems like it was underplayed a little bit.
She was quiet when she was first born. They did a C-section and they had her, and we kept waiting for that cry. And we did hear it, but it was little.
She was 4 pounds 10 ounces, so she was very small. She had all these health issues.
It's really common. It's the most common congenital virus.
So I'm going to talk a little bit about what congenital CMV is and get back to Caitlin at the end of the talk. And so what is CMV? CMV is a herpes virus along the same families as zoster and HPV. It is the most common congenital worldwide infection, and thus it's an important issue both in the developing and the undeveloped countries. Very important issue in terms of neurodevelopmental delay. And it is a very common cause for non-hereditary sensory hearing loss. And so in our field, we all talk about genetics, which is certainly an important issue. But unfortunately, congenital CMV infection is not highly emphasized in our field. And yet, it can account for up to 25% of all pediatric hearing loss. And so transmission, there's sort of two common routes that are discussed. One is the seronegative mother who never has been exposed until, unfortunately, during a pregnancy and then develops what's called a primary infection. And then there's a mother who's been previously exposed, but through secondary infection, either through reactivation or through another strain, contracts the infection. And then it results in a sort of host or spectrum of presentation to newborns, where it can be asymptomatic, symptomatic with evident disease, as well as asymptomatic with isolated sensory hearing loss. And so in the symptomatic condition, this occurs in about 10 to 15% of children. This can unfortunately cause fetal demise, prematurity, as well as a whole host of other conditions. This shows you a child who has sort of the dissemination of petechiae. You can also on CT scan see these sort of characteristic calcifications. The asymptomatic group is by far the more common, where they don't present with any signs or symptoms, but even this group are at risk to develop sensory hearing loss. And so the studies have shown that about 6% of children with congenital CMV will present with sensory hearing loss, and this number will increase over time. And this is one of the sort of devastating aspects of this infection, is that these children then can develop progressive loss as they get older, up to 25%. And when you look at this in terms of a frequency or incidence or prevalence, if you compare it to hearing loss, Down syndrome, cleft lip and palate, spina bifida, and other hosts of conditions, congenital CMV is actually much more common than these other well-known conditions. As you know, a few years ago, Zika really hit the headlines in terms of awareness, and this is certainly is a devastating infection too. Certainly the Brazilian cohort demonstrated the effects in terms of microcephaly, and this is a CDC map that shows you in 2016 sort of the imported cases of Zika infection throughout the country, and certainly this is a big issue. And fortunately, that number has really dropped as of 2019. This is the map in the United States, where you really don't see very much penetration of the infection. However, to the right shows you the prevalence of congenital CMV by state, and you can see that this is continuing to be an ongoing problem. In fact, in the southeast, where Louisiana is in the sweet spot here, this is an area of high prevalence for this infection. If you look at it from a standpoint of research, if you look at the reporter database, there's over 400 NIH-funded projects related to Zika infections, and yet for congenital CMV, there's only 78. So unfortunately, congenital CMV, although a major public health issue, it's very common, there's really a lack of research in this important condition. And then I wanted to, again, highlight the importance of Louisiana and Shreveport in terms of congenital CMV infection. Now, in terms of diagnosis, best obtained when the child is young, usually under 2 to 3 weeks of age, because you need to distinguish this from postnatal infection, which is not associated with hearing loss. It is associated with other sequelae of the infection. Urine culture or PCR is recommended. Saliva is good. You have to be careful, though, because you can get false positive results, presumably from breast milk contamination. The other option is dry blood spot testing, and so as you know, all children in the United States undergo a neonatal dry blood spot screening for metabolic diseases. And so this is an opportunity in an older child who may present to you where you're concerned about congenital CMV infection. The landmark study by Suresh showed about a 34% sensitivity, so a concern that way. The more recent studies indicate that maybe the sensitivity through better DNA extraction might be closer to 70%. That's from Mark Schleiss's group and the CDC Collaborative. However, that's still a low number that certainly makes mass screening for this modality a concern. So my sort of introduction to CMV came probably about 10 years or so ago, when I was fortunate to be a chapter champion for an EDDI conference in Washington, D.C., and I had the opportunity to meet Amy Donahue, who was at that time the director for NIDCD. And she had lamented the fact that there was not very much basic science research being done on congenital CMV infection. And I had learned about it in my residency, but actually did not recall at that time ever seeing a child with congenital CMV infection. And so I became interested in this topic and started calling. And I remember just calling up Mark Schleiss one day saying, hey, you know, I'm very interested in this sort of issue, and, you know, would you be interested in collaborating? And expecting, you know, thinking that probably he thought I might be an insurance salesman, and hanging up the phone, he actually answered me and talked to me, and we've actually established a long-term collaboration over the years. David Hilliard is a medical director at our ARUP laboratory. This is our reference laboratory that performs a number of different diagnostic tests, and with the collaboration with him, we're able to develop CLIA-validated saliva and dry blood spot CMV PCR tests. So this is sort of my evolution and interest as I started getting into this. And around that time, this is about 2012 or so, I was introduced to DD. Now, DD at that time was 19 months of age and unfortunately developing progressively worsening hearing. She had failed her newborn hearing screening, and during her additional workup was found to have maybe a mild loss in her right ear on a click ABR. And interestingly, audiology just recommended coming back 9 months later. Unfortunately, during that time, what was not identified was that she had a intrauterine ultrasound that showed some abnormalities in her ventricles, and that was confirmed on subsequent testing at birth. By the time she saw me, I did not see any major otologic findings, but by this time, her mild hearing loss in that right ear had progressed to a profound loss in her left ear, which was previously normal, now became moderate. Now, by then, we had developed these sort of CLIA-validated assays for CMV detection. So the first thing that she may have been probably the first child that we actually had CMV testing using saliva assays that came back positive. And this does not confer a definitive diagnosis because at this time she was about 19 to 20 months of age. And so we did obtain through the Department of Health her dry blood spot. And so we were able to run that dry blood spot sample, and that was positive. This then established a definitive diagnosis of congenital CMV infection. Now, at that time, we really didn't know about what sort of treatments, but we did elect to treat her with a 6-week course of valganciclovir. Unfortunately, her hearing continued to progress to the point where she had bilateral profound loss, and thus she underwent cochlear implantation. But the issue with DD, and this is a child that I've come to unfortunately have to deal with and work with the families all too often, is that DD is actually Daisy Dutré. Daisy Dutré is the granddaughter of former Representative Menlove and is the daughter of Sarah Dutré, who's currently a board member of the National CMV Foundation. And I actually vividly recall my conversation with Sarah, the mother. Sarah was mentioning to me that she had never heard of this condition, that she was devastated, obviously, about all this, and felt that something needed to be done. And I unfortunately hear this all too often, and actually did not think too much about this until about 2 weeks later when I was summoned to a Department of Health meeting with Representative Menlove, all the Department of Health, EDI personnel, Mike Werner, as well as Jim Bale, who are researchers in the CMV field. And it's interesting because I could never get these guys in the room together whenever I asked for them to meet with me. But we all were there, and we all really essentially brainstormed about these issues. We brainstormed about the fact that when you see a child who presents with you who's maybe 3 months of age, this is sort of the algorithm that I've used in trying to identify or diagnose a child with congenital CMV, which really is just to show you that it's somewhat complex. We talked about universal hearing screening, and that's a very successful program that's been implemented since the 1990s. And since hearing is the most common sequelae of congenital CMV, we talked about, well, maybe we can somehow incorporate the successful universal hearing screening with a CMV screening program. We also talked about the issue of awareness. If you look at sort of this graphic that compares the incidence on the left-hand side of congenital CMV compared to like fetal alcohol syndrome, Down syndrome, spina bifida, congenital CMV is by far the most frequent or common, yet on the right showing awareness of this condition, that CMV is last. And so we also talked about these issues. And this sort of discussion and continued follow-up resulted in this House Bill 81, which essentially the first two components of this are a Department of Health awareness, where they're charged to provide educational programs to caregivers as well as to providers or other organizations that offer childhood services. So really to address the awareness question. And then the last one is a screening program in that children who are found to fail or refer on the newborn hearing screening are to undergo CMV testing before 3 weeks of age. And so this legislative effort, which was also involving Carl White, who's a very big proponent of universal newborn hearing screening, Jim Bale, resulted in the signing ceremony within about 6 months of introduction of the bill, which was passed unanimously. On the left is Sarah, Daisy, Representative Menlove, and then Governor Herbert. This is the signing ceremony, and I just want to bring to your attention my key involvement in this is shown right here. Now, actually, I was very much in the background with this. But this was a very gratifying and really, in some respects, amazing transition that occurred in Utah over a period of about 6 months where we were doing no screening to now doing statewide screening. And so Utah became the first state in the country to implement a statewide hearing-targeted CMV screening program. And really, over the years, that has really changed in that a number of states throughout the country have either implemented an awareness or educational program, and a number of them have actually implemented a similar hearing-targeted screening program. And so this has been really gratifying. This is really a tribute to parents who unfortunately have had to deal with this devastating condition, as well as a number of providers and clinicians and researchers throughout the U.S. So over the past 6 years or so, at least in Utah, we've tried to really broaden and try to improve our ability to identify more children this way. And so to expand upon the hearing targeted program, we have started to use what's called an expanded targeted screening approach. And I just want to bring this to your attention. These are sort of the key components where, in addition to the failed hearing screening, we look at history of maternal infection, SGA, intracranial sort of findings or evidence of intra-abdominal calcifications, evidence of elevated transaminase or elevated direct bilirubin that could not be explained, petechiae, head ultrasound findings, unexplained thrombocytopenia, or unexplained hepatosplenomegaly. So we've looked at these sort of characteristics to see if we can try to identify more of these children, and yet do this in a way that's maybe doesn't break the bank, that's implementable, that doesn't really have to shift our sort of approach or policy in a huge way. And I just want to share, these are some data that we're going to be presenting actually later this week at our national meeting. We screened about 750 newborns using this approach out of about 85,000 children. We identified 21 of these children with congenital CMV infection. If you look at this from a cohort study in terms of cases per 100,000, that comes out to about 14 cases per 100,000. The reason that's an important number is that studies out there where they've not implemented any screening program have identified on average about 4 cases per 100,000. So again, this just shows you, I think, indicates the impact of this sort of approach. It's not what we like it to be, because we think that the prevalence of this should be closer to 25 to 26 cases, but again, I think this is a direction in the right way, and this just shows the distribution of the children that we identified in this manner. So this is a way that kind of builds upon a hearing-targeted screening program by identifying more of these children, but maybe doesn't necessarily do this by a universal sort of approach. Now, I want to now kind of jump now to, after kind of explaining hopefully to you the importance of this condition, I want to provide you some rationale for why we may want to consider screening. And so in 1968, the WHO commissioned a report on screening because even in those days, screening was controversial. And James Wilson and Gunnar Gunger worked together in developing this document called The Principles and Practice of Screening for Disease, which really is a classic and is really a seminal sort of foundation for programs that are looking at screening. And really, this is it's a lot of text, I apologize, but I think it's an important idea that they wanted to present, and that is that the idea of screening is essentially simple, but the path of successful implementation of the screening in a way that we don't want to cause harm to children or to the people who are being screened is not a simple process. And so they came out with 10 criteria that they recommended that you need to sort of assess when you're looking at potentially developing a screening program. And I wanted to sort of go through a mental exercise of how a hearing-targeted or expanded screening program would fit, or would it fulfill the criteria of screening. And then there's 4 major headings. There's knowledge of disease, knowledge of tests, treatment of disease, and cost considerations. So I wanted to start with number 1. Number 1, I think we've sort of addressed already in the beginning of the talk, in that congenital CMV is an important condition. if you look at the incidence of congenital CMV compared to all the metabolic and endocrine disorders that are currently being screened in the U.S., the incidence of CMV is actually higher. And so that also, I think, supports the contention that this condition is certainly important enough to be considered for screening. Now, it must have a recognizable latent or early symptomatic stage. And certainly, if you look at it from a hearing standpoint, we know that about 10 to 25% of children will develop sort of this asymptomatic period, but then go on to develop a delayed onset. So this does fulfill the criteria of a latent or early symptomatic symptom. We need to also understand that we have to understand the natural course of this in terms of understanding its sort of path. And there are a number of longitudinal studies through Demler's group at Baylor, as well as the UAB group at University of Alabama, that have shown the sort of natural course, especially the hearing loss component of congenital CMV. There needs to be suitable tests for examination, and there are saliva and urine CMV PCR tests that are suitable for screening. There are studies that indicated high sensitivity and specificity. You do have to be careful, as I mentioned earlier, about positive saliva results, and so we typically recommend a confirmatory urine sample, either a PCR or a culture done early, to avoid the potential confounding false positive rates from breast milk. The test needs to be acceptable to the population, and this is an important study by Din et al. Through the CDC. Essentially, they had a national survey of families and asked them these 3 questions. What you find here is that the vast majority of families would want to have their child tested for CMV, even if the doctor or hospital did not perform the testing routinely. That 84% of these families would want to know if their child has CMV, even if he or she never develops any difficulties. And families are also willing to pay for this, in that they'd be willing to pay, in this example, $20 to have their child tested for CMV infection. Number 6 is the case finding should be continuous. It should not be a once-and-for-all sort of project. And in fact, we know that congenital CMV is like this. It's a lifelong condition. It unfortunately develops latency in those who are infected by the infection, and that the process does evolve over time. And thus, actually, there have been recommendations through consensus statements that children who are identified with congenital CMV infection should undergo audiologic surveillance testing continuously, at least pretty aggressively in that first 3 or 4 year period, and then continuing on even into adolescence. And this is one citation is from Rawlinson et al. From Lancet Infectious Disease that was published in 2017. Number 7, there should be accepted treatments for patients with recognized disease. And the way to address this question, I sort of broke this up into those sort of 3 categories of infection that involves these children. When we talk about treatment, a lot of people, I think, think about antiviral therapy. And the antiviral medications that are considered are typically ganciclovir or valganciclovir. The valganciclovir is a prodrug of ganciclovir. That's the oral administration. The ganciclovir is the intravenous administration. They both are believed to block viral replication. And the valganciclovir typically will convert to the ganciclovir through these enzymatic esterases. Now, it is FDA approved to prevent CMV infection in pediatric patients who are receiving transplantation. It is not approved for the treatment of congenital CMV infection. However, there are a number of studies that have looked in this. These studies are, some of them are randomized double-blinded clinical trials. This is an older one by David Kimberlin's group, the Caskey group, published in 2003, looking at the potential efficacy of ganciclovir. This is a placebo-controlled, non-blinded study. And essentially, it demonstrates that those children who underwent ganciclovir treatment had better hearing outcomes compared to the children who did not undergo treatment, following these children more than 1 year or so. And then a more recent study, which was really a duration study comparing 6 weeks for 6 months, looking at a 2-year follow-up, showed, again, better hearing outcomes in those children who were treated for a longer duration, both looking at it from either those children who initially had hearing loss, as well as even those children with normal hearing. Both of those parameters had better outcomes in children who underwent the longer therapy. They also looked at neurocognitive outcome measures using a Bayley-3 and showed, at least in terms of language and receptive communication scores, that children who were treated for the longer therapy had better outcomes from that standpoint. So we know that, at least in the symptomatic group, we can offer antiviral therapy. I think that's really become sort of standard of care throughout the country in these severely affected children. In addition, when you're talking about treatment, it's not just antiviral therapy. It's also treating the whole child. And so ophthalmologic evaluation, in my opinion, is very important to rule out for sort of the sequelae from retinitis infections, as well as a neurology evaluation because of the known effects in the CNS. These children should undergo serial audiologic testing because of the known risk for progressive loss. And in those children who are found to have sensory hearing loss can undergo hearing amplification and possibly even cochlear implantation just to optimize their speech and language measures, as well as the issue of antivirals. Now, when you look at then the other group, what about the asymptomatic child with sensory hearing loss? This is a study that we published not too long ago looking at our outcomes in Utah in children who were identified through the hearing targeted screening program. The bar here on the left here, which is blue, shows you the effect of timely diagnostic hearing testing in children both 2 years before and 2 years after implementation of the law. And essentially just wanted to show you that there's been an increase in those children who underwent timely diagnostic testing. If you also look at it in terms of those children who got screened or not screened for congenital cCMV infection, you're seeing that the children who underwent cCMV screening in general also had more timely diagnostic hearing testing. Now, why is that important? In the hearing field, that's really important because studies have shown that if you identify a child with hearing loss and treat them, and that could be through early intervention, it should be through amplification or cochlear implantation, those are the children that are going to most benefit in terms of speech and language measures. This is a study from Christy Yoshinaga's group back in 1998 that shows in blue if you intervene or try to address their hearing loss early compared to those who are treated later, which is shown in orange, that the children who are treated early do better in terms of speech and language measures. And this is really the rationale, the crux of the universal hearing screening program, is to identify these children early, treat them early so that they can optimize their speech and language. And so the hearing programs throughout the country have in general been very successful in that over 90% of children in the United States undergo universal hearing screening. But one of the big challenges with this program is that many of these children are lost to follow-up. In fact, about 50% of children should be getting diagnostic hearing evaluations by 3 months of age. Actually, 100% should be, but unfortunately in the United States, it's closer to 50%. And so what we found is that through this hearing-targeted cCMV screening approach, not only did we help the children who were identified with congenital cCMV infection, we also helped the children who failed their newborn hearing screening. And so that really helps a much larger group or cohort of children through this program. Now, what about antiviral therapy? This is a child that I saw shortly after implementation of the law. It was a 26-day-old infant who presented with CMV-induced sensory hearing loss. How do we identify this child? Again, this child failed their newborn hearing screening, and through that triggered saliva and urine CMV testing, which were both positive. We were able to obtain that before 3 weeks of age. In fact, one of the sort of gratifying aspects of my practice this day is that it is rare that I see a child who failed their newborn hearing screening who hasn't already had CMV testing by the time they come to see me. So I'll oftentimes see the child when they're 1 or 2 months of age, but by then they've already had their CMV testing done. And that's kind of the standard of care in Utah, and it's gratifying to see that this is also happening throughout the United States. Now, this child also had ABR testing, and so it was found that this child had a left profound sensory hearing loss. Ophthalmologic evaluation was normal, head ultrasound was normal, and so this is a child with congenital CMV with isolated sensorineural hearing loss. And so we did treat this child with antiviral therapy for 6 weeks. We've been following this child probably now for about 6 years, and this child has done very well. This child has had stable hearing. Her speech and language milestones have been on target. And so the question is this really the way that we should be treating the isolated sensorineural hearing loss children? And we don't know that answer. There's lack of consensus. There's lack of evidence-based data to indicate whether these children would benefit from this. We need to be careful because this antiviral therapy has some effects. It can unfortunately cause neutropenia, and there have been at least animal studies to indicate effects in terms of carcinogenesis as well as fertility, at least in animal studies. And so, again, we don't want to offer a treatment that in the long run is not going to provide any efficacy for these kids. However, if these children could benefit in maybe preventing further progressive hearing loss, preventing cochlear implantation or speech and language detriments, that's an important treatment modality that we need to offer. And so I'm very much been blessed to be involved in this NIH-funded clinical trial. This is now, we now have 25 sites. We're planning to get to about 40 sites, so it's a very big study. Essentially, the design is that it's a randomized double-blinded clinical trial where one arm will be placebo, the other arm will be treatment. We're going to be looking at hearing measures, speech and language measures to try to, again, determine efficacy as well as the safety of this drug. This is just showing a map of some of the institutions that are involved currently, and I wanted to highlight Louisiana because our hope is that we will also get LSU to participate in this trial. So that really, going now to the sort of treatment arm for the asymptomatic with children with sensory hearing loss, what we can offer for treatment is serial audiologic testing, so we can identify these children early if they are to develop progressive loss. In those children with hearing loss, we will offer amplification or cochlear implantation, speech therapy as needed, and go from there in terms of antiviral therapy depending on the results of the Valier trial. Now, what about the last group, which are the asymptomatics? These are the children who present with no sequelae from infection and really are not expected, you would think, to develop any sort of difficulties from the infection. Now, one would ask, well, these are children that probably we would not identify through our screening because our expanded screening is really based on symptomatics, signs like the tiki eye, or failed hearing testing. Well, the surprising thing that we have found is that about 1/3 of the children that we identify through this expanded screening program actually are asymptomatic. So you actually do identify these children. Now, are these children truly asymptomatic? Well, we know through epidemiological studies that these children are about 10-fold increased risk of developing progressive hearing loss. So they aren't really asymptomatics from that standpoint. And this is an interesting study by Carnewall et al. From the Netherlands, part of their Crocus study. And they did look at the asymptomatics who actually at that time did not show evidence of sensory hearing loss or other sequelae, but showed that there was still some issues with these children in terms of expression, comprehension, fine motor, gross, even general development in these asymptomatic children, that there was a higher prevalence of these issues in this cohort. So again, from a treatment standpoint, what can we offer if we were to provide a screening program? We would offer serial audiologic testing because these children are at risk to develop progressive hearing loss. We would provide amplification or CIs if they are found to have hearing loss. And yet we also know that these children are at risk to develop speech and language and maybe physical therapy issues. And so we want to offer or be able to identify those children who are having difficulties and offer these services if it's found that they're not hitting their milestones. So that addresses number 7 of 10. We're getting there. So number 8 is facilities for diagnosis and treatment. Is that available? And in fact, because we are piggybacking onto a successful universal hearing program, that is one of the advantages of an expanded targeted approach, is that we can use the infrastructure that's already there for universal hearing screening with this approach. And that I found that to be very beneficial in terms of tracking these children, because there's EDDI programs throughout the U.S., there's databases, and there's personnel involved in the universal newborn hearing program that we can then ask them to then add the CMV component for tracking these children. In terms of laboratory testing, there's national reference laboratories that are available that have CLIA validation for screening for assays. Now, is there agreed upon policy concerning whom to treat as patients? In terms of policies of treatment, in 2019, not that many months ago, the American Academy of Pediatrics Annual Leadership Forum actually passed a resolution recommending education of primary care physicians, EDDI coordinators, and others of the importance of timely diagnostic testing for CMV. In fact, they also recommended that in those children who fail their newborn screening, CMV testing should be performed. And there is also a publication in our ENT literature in Laryngoscope that is a best practice on hearing target early CMV screening, recommending that children who fail their newborn screening should undergo CMV testing. There's an AAP policy statement that's pending that I've been honored to be involved in, which I have not gotten to yet, but we're hoping to get that through in the next few months. The last issue is cost, because cost in this day and age is so important. We need to be cognizant of the costs and expenditures of any sort of screening, as well as cost to family. There are some studies. There's a study from our group from Bergevin who looked at the cost of treatment looking at sort of the statewide program in Utah. We looked at the Utah government administrative data as well as multi-hospital accounting data. And we found that if we were able to prevent a child from obtaining a cochlear implant through antiviral therapy, that would save or offset any costs from any sort of statewide screening program. Another way of looking at this is more of a cost-effectiveness model, and this is Soren Gant from Vancouver. And this was a collaboration with Suresh Palma and Karen Fowler from the CHIME study, as well as our group in Utah. And this I wanted to bring to your attention is if you had a screening program where maybe the cost was about $50 per test. The cost to identify one child with CMV-related hearing loss is about $90,000. If you do a targeted screening approach, it's about $4,000, so much less. If you compare this to this study that's from Karen et al. In Pediatrics in 2002, this looks at the cost for universal hearing screening. So just to give a sense of another sort of approach for screening, their cost to identify one child with hearing loss is $21,000. So these numbers are, I think, comparable, and certainly a targeted screening or expanded screening approach was also comparable to the $21,000. So an expanded screening approach, because you're looking at additional measures and additional testing, is a little bit more costly than the hearing targeted, but still less than $21,000. This is $21,000 from 2002 dollars. So now what about Louisiana? So Louisiana, if we looked at, say, universal, we looked at expanded, for instance. For universal, it would be 21,000 children who would need to be tested per year. Expanded would be about 1,800 annually per year. If you do hearing targeted, it would be about 600 or so. If you look at just the cost from a cost of the test, assuming that the cost is about $50 per test, it comes out to this amount. So about $3 million for universal, $90,000 for expanded screening. And then you have to think about logistics. So this means personnel costs. This means transportation of samples, laboratory infrastructure, and then maybe the biggest hurdle is insurance. Because how do you justify to insurance that you want to screen a child who's asymptomatic, or at least that you're screening them? And so that's at least been a challenge in other institutions and certainly been a challenge in Utah in terms of when you're trying to look at universal screening. And then you need to educate these families because 85% of these children would be expected to be asymptomatic, so they're not going to have any obvious signs or symptoms and may not even be expected to have any sequelae. And so education is really important, and you need to counsel these families. Yet you need to also warn them about the risks of progressive hearing loss and having vigilance and surveillance testing. And so that also is a cost. So how do you start an expanded targeted CMV screening program? And this I'm kind of providing you some data based on my experience in the 25 sites, looking at about 12 of them more specifically. We kind of looked at those sites that were most successful and those sites that are struggling in the program. Because to enroll into our clinical trial, to those who would be eligible, we need to identify these kids. So every single site that's involved in the Valier trial, the vast majority of them actually did not have any screening program when they signed on. And so this has been sort of a national experiment. This has been a way to say, okay, we want you to enroll in our trial, we want you to participate, but before you do that, as standard of care, you need to make the decision to start screening. And by doing that, we then ask the questions, well, what is it that made a screening program successful? What made a screening program not successful? And one of the key sort of points is that you need to get all the members, all the people who will be involved in this screening process and the follow-up to agree that this is important. And so you need infectious disease, you need neonatology, ENT, audiology, nursing, especially nursing, and leadership to make this successful. And then you may want to think about doing a gradual adaptation. This is something that Mass Sinaier was very successful in doing this, in that they said, okay, we're not going to just on day one just implement this whole new program. We're going to do this a step at a time. And so they decided, because the NICU kids are kind of a captive audience, and so they're not going to be moving too much, maybe start in the NICU first, get sort of a familiarity of the screening process there, and then once that's adopted, then start expanding it to the newborn nursery. And so that's what they did, and I thought that was a good idea. The other thing in those networks where they have one hospital among 10 or 12 other hospitals, they started with one hospital first, get that program working successfully, then gradually adopt it to all the other birth hospitals. That's been done at Northwell, Long Island, that's been done at CHOP, that's done at Pittsburgh. And so that's another thing, that if you're starting to implement something in a network, start small and then build from there. I also want to bring to your attention sort of the leaders in these different institutions that were really important in the success of the screening programs. Angela Shoup is actually our co-investigator for the Valier trial. And so she worked with Pablo Sanchez when he was at UT Southwestern in actually implementing the first hearing-targeted screening program in the United States, which is still ongoing at Parkland. Anna Murad, who's at Vanderbilt, really kind of took it upon herself. She said that any child who's identified with congenital CMV, let me know. Email me those results so that I can make sure that these kids are tracked and that these kids obtain adequate follow-up. And she convinced all the different private practice groups that work within the neonatal newborn nursery to work together to agree on targeted screening. So you need that sort of leadership and that sort of commitment to be successful. Pablo is now at Nationwide. He's continued on with his legacy in terms of really getting the hearing targeted screening program in Nationwide to be successful, and their group is actually implementing universal NICU screening at this stage. Then Stephanie Moody is in pediatric ENT at King's Daughter in Virginia. Virginia just passed legislation to implement it statewide, and so their group is amazing. Within 3 months, they actually implemented hearing targeted screening with over about an 80% success rate in those children who are eligible, and they've already identified 2 congenitally infected children in this last month through this approach. And again, you need that sort of leadership. You also need to consider urine, because urine is an easier sample to deal with. If you have a positive saliva, you need to have the child come back in, and that can be a challenge. Some centers, what they do is if the child fails the first hearing screen, they automatically get the urine then, so they don't have to delay, because that can be difficult when you're trying to get these kids discharged from the hospital. And then only order the test or only implement the study if the second newborn hearing screening also fails. You may want to consider incorporating this as a quality improvement program. And then communication is really important, because you have a hearing screener, you have nursing, and you have an ordering physician. All 3 of them need to communicate well in order to get this process working. And the way to do this might be through conditional order sets. That's one way that it's been successful in some programs. And then you need to have someone who actually checks the results. You need to have someone who actually follows up. And these are 3 individuals that in the Valier trial, who I found to be very successful in following up. So they're like the go-to person. Any child in any of the birth hospitals, they have a positive result, they know to call Alexandria Durkin at CHOP. They have her cell phone number, her email number, and so she'll be able then to plug these families in for additional evaluation. Brittany Luscombe and Amber Schaefer are other individuals in their institutions who are sort of the go-to person to ensure that these kids are being tracked. And so you need to track your results. You need to determine the percentage of those who are eligible who actually get CMV testing. You need to involve the primary care physician. They're the ones who probably have the closest relationship to the families, and so they need to be notified of the results. Oftentimes the institutions use the primary care person as the go-to person to talk to the families, and then are involved in the management afterwards. Expect a lot of negative results, because I get a lot of calls and discussions with our sites saying, I just haven't had a positive CMV result. It takes time. Part of it is just the screening and getting the numbers up there, and you're expecting probably about a 3 to 5% hit rate. So that means you're going to have 95 out of 100 children who are going to have a negative result. But when you get a positive result in these kids, it's hugely impactful for these families, and these are the kids that we're trying to identify. So in conclusion, I wanted to hopefully share with you my feeling that congenital CMV infection is a very important issue, that CMV screening should be implemented now throughout the United States, that you can start a program here. I guess I was told that actually LSU has started implementing a hearing targeted program, which I congratulate you for, and I hope that you can build upon that and grow that. I do want to go back to Caitlin Hill, if I can, if there's a moment. Let's see if I can do this correctly.
I didn't think that,
just so they know what happened to her.
Down the road, we would still be in speech therapy and going to doctor's appointments and dealing with effects of this one virus that caused so much damage.
I was born being really sick. And then somehow I was getting deaf. So when I was at least 4, I got my hearing aid.
So now she is 7 and she is completely deaf in her right ear, and she's got a moderate loss in her left ear. And so she uses a cochlear implant on the right side and a hearing aid on the left side.
I'm pretty happy that Jesus made me up with my mom, because I don't get in trouble a lot.
She doesn't see those kind of dividing lines that we see. Everybody's her friend. It doesn't matter who they are, how they look, how old they are. They're all her friend, and she's so open and she's so happy, and she'll give anybody a hug. And when she grows up, she wants to bake cookies and give them to people. And that's just Caitlin. She just is loving.
Nobody knew what it was, but I wish we'd been given a little bit more information.
It's not hard. It does take a little bit of a shift and some intentional behavior, but you do that all the time when you're pregnant anyways. And you're accustomed to that. You understand the importance. And I think that moms are willing to do anything to protect their kids as long as they know about it.
a perfect girl. I have a perfect home, perfect mom and dad, and most of all, perfect sisters and brothers. I am the perfect girl in my family. I'm a little too perfect from the others because they are not there. So, too bad for them.
So I want to acknowledge the CMV group. That's a team effort to be successful in these sort of screening endeavors and these projects. This is a training session from last year. Just want to let you know I'm not in this picture, but I'm with them. And then I also really want to acknowledge the families and want to thank you for coming here too. In terms of sharing your experience, this is certainly difficult for these families. The Hill families in North Carolina. Kristen Spytek is the president of the National CMV Foundation. Her daughter Evelyn had congenital CMV, unfortunately passed away from this condition. And it's really, without these families, I think we would certainly not be where we are right now in terms of trying to push this in terms of awareness and screening. So thank you for your attention. Welcome any questions that you may have.
Thank you for a wonderful presentation. I think that really provided a wonderful view.
Yes, so we talked a lot about hearing loss, and they discussed this all the time in CMV meetings, general meetings. But a big aspect, which was not discussed today, I think is really important, is thinking about prevention. And there's certainly plenty of evidence, numbers say, depending on the study, 20 to 30, 40, maybe as much as 50% diminution of transmission to pregnant women by simply being careful around other body fluids. I realize that's a touchy subject because you can't tell a pregnant mom who has children not to touch, kiss her children and stuff like that. But those sort of data exist that in the context of both knowledge from OBs to parents as well as in mitigating a lot of the issues before we get that point. Sort of in that context, what's your view on, obviously screening is going on, they talk about this all the time in these congenital meetings and CMV meetings as well, but that is an area that can potentially have very profound consequences in mitigating really the disease. And when you
that's a
numbers
great
with what the CHIME study has done and the UAB with, reinfection is just as important as in a seropositive mom as primary infection seronegative. That ends up being a potentially, really will have a dramatic effect on this disease.
So those are really great points. In fact, I had a few slides on prevention, but I wanted to be cognizant at the time and wanted to focus on certain issues that I wanted to bring to your attention. Prevention is a key issue. I actually have submitted a grant that didn't get funded, but we're going to resubmit again, looking at prenatal, because prenatal, I think, is the best opportunity to really bring these issues to the attention of the families. I think in many respects, once the child is born, it's too late. That one thing is we can at least provide awareness to these families, offer them some of the data. The data, unfortunately, there's not at least at this moment, a randomized clinical trial that has looked at preventative measures. And as you may know, ACOG has said that they do not recommend counseling parents prenatally about congenital CMV. They mentioned that there's a lack of evidence supporting educational measures, preventative measures. They also mentioned that it's too burdensome to providers, OB-GYNs, to be offering this. And so in the U.S., there's really a lack of any sort of involvement in the obstetric community in respect to this condition. Yet, they're obviously involved in many other issues like influenza and other communicable infections. So, again, I agree 100% with you that prenatal education is really important. In fact, what our team has done is we've developed some educational modules, and we're going to try to, again, resubmit for a clinical trial that's really looking at it from the prenatal side of things to demonstrate efficacy. And then the other thing that you alluded to in terms of primary and secondary infections, a lot of emphasis in the OB community has been identification serologically on primary infection because obviously secondary infection is so hard to diagnose, and there's really a lack of studies looking at preventive measures for those seropositive moms. But certainly one would expect that the preventative measures for that group would be just as effective as for those with primary infection. And so there's a lot that needs to be done on that side that hopefully in the next months or years we'll have more data and maybe hopefully enable the ACOG group to change their policy to implement a much more meaningful approach for these families.
Right, and I think, what doesn't come across a lot is that CMV is, when you really think about infection, it is really unique in the context that seropositivity goes up. So does congenital infection, where, when seropositivity went up with Zika, congenital infection goes down. It was classic viral infection and immunity. And CMV is really one of the few viruses that, both go up together. And it's sort of a shame. I mean, I show that same slide when I teach, I don't know which of the students in here or former students I taught, but show that data in a different format of, congenital CMV being the most important, and then obviously different studies have 10, 14, 15, 18, 20% moms know about it. And it's, I think the knowledge aspect is so fundamental to that. And, I know, again, when we go to the congenital meetings, I always talk about this. Every parent I've talked to says the same thing, had no idea. And yet, me being a CMV researcher, I had my wife checked for all 3 pregnancies, and we were both apparently seronegative going into at least number 3. So, but I was the one that paid out of pocket because insurance wouldn't cover it. But I think it's a knowledge issue, and with the screening that you're doing, I think obviously backing it up as to go along with the potential, whether universal or the targeted screening, will have, I'd be surprised if it had dramatic effects based on the studies I'm aware of.
And you bring up some really important points. One that I think is commonly not recognized, that being seropositive doesn't confer complete protection against infection. In fact, in the developing world, more children contract congenital CMV in mothers who are seropositive. And so that's a big issue, and that's certainly a challenge in developing a vaccine that would be effective in preventing transmission. The other issue in terms of awareness, this is probably data that I'm not proud to share, but I think it's true that even though in Utah we've implemented a hearing-targeted screening program that's been in existence for about 6 years, when we survey families about their awareness of congenital, just awareness of it, it's still low. It's still probably in the 15th percentile. So even if you implement a statewide program and you do all these efforts, we have billboards that show families with, and kids with congenital CMV, we probably need a CSI episode, or we need a Star Trek episode with a congenitally infected child who overcomes all those issues to really bring it to the attention of the public. So those are real big challenges. Yes. You have a question?
Yeah, that was an excellent presentation where you put a picture and a face and a voice at the beginning and end to get your message across. My question pertains to the epidemiology slide you presented from the CDC earlier and alluded to the global epidemiology. As we all know, China, developing countries, the prevalence is very high. So why not concentrate on that southeastern area to get a better bang for the buck in terms of cost effectiveness? What are your thoughts? Because again, these are not cheap as you presented. Once you fail a hearing screen, you're doing ABAR, and ABAR can be repeated, so all those costs act up for this return. So my guess would be that your best bet would be in that. Why is that area singled out unless there's you guys in mountain area have a different population? That's what my understanding is when I visit there all the time. So what is it that's making that prevalence so high? Just like China, for instance, has a very high seroprevalence.
Well, yeah, I mean, I think what you alluded to is that they're different populations. And so there's differences in terms of prevalence in different socioeconomic groups, in different racial groups too. I don't think we understand, at least I don't understand the biology in terms of how that works. I do think that your point about emphasizing more resources in areas where there's high prevalence makes a lot of sense to me. That's part of the reason why I flew down and drove out here, is because I wanted to at least share our experience in Utah. Utah actually is a relatively low prevalence state. We probably have about 0.3%. I imagine here it's double that amount easily, though I don't know if there's good numbers to support. So I think there's as I mentioned there's a lot of research being done on Zika. There needs to be more research on CMV and some basic questions in terms of just prevalence, preventative measures, which I think are not really high cost issues that we can make a difference. I think certainly we need to wait for some of these important clinical trials. There's a toddler study that's going to be coming out in the next 6 months. And Vossen has a study out from the Netherlands that's also going to be looking at the isolated. But even now, there's things that I think we can do, and we can do in this state, that could have an impact on families. So,
what about breastfeeding? Because that's the commonest cause of acquired CMV in the United States as opposed to many other parts of the world. And you've got a false positive, perhaps because of the intermittent shedding of the virus or whatever, you're missing it early on. Would you all, either of you, comment on that?
Well, in terms of diagnostic testing, as I mentioned earlier, I think you have to be realistic. You might be in a setting where it's just too difficult to do a urine. You have a child who just got circumcised, or that child's going to be discharged soon. You may it's maybe better to get a saliva sample at that time. And then Meridian has a FDA-approved assay, a Lumigen assay, that I believe, last time I heard, it might be as cheap as $35. So it might make a lot of sense in your situation to use a saliva assay in that situation. You just need to have then a process that if you have a positive result, that you get that child in right away to get a urine, just to confirm. I had a child who was 3 or 4 months of age who had a positive saliva, had a head ultrasound. They thought that the head ultrasound indicated some findings suggestive of a congenital CMV infection. The community infectious disease started the child on antivirals. I saw the child when the child was about 2 or 3 months of age. First thing I did was I got a urine. It was negative. The child, I had an MRI. I talked to my pediatric neurologist because I'm not a pediatric neurologist. We got an MRI scan. It was normal. Stopped the antivirals right away. This child had a connexin mutation that was causing this child's hearing loss. This child did not have congenital CMV infection. So that's what you don't want to do, is you don't want to mistakenly diagnose a child with congenital CMV infection, start them on antivirals with all the potential adverse effects if it's not even a child with congenital CMV infection. So that's my thought.
If you're going to use the saliva screen, you have to wait. The standard is to wait at least 1 hour following breastfeeding to allow any maternal CMV to disappear.
But I've had a few kids who we waited 90 minutes and still was positive and didn't have congenital CMV infection. So it's just, it's a challenge.
That is a problem. Andy?
So I know that some of those clinical trials, I don't know if they have any evidence. I know they've done the 6-week and 6-month with the symptomatic for hearing loss, and as I recall, the data was positive that treatment with valganciclovir had a positive outcome. I guess they were starting the clinical trial. Is there any positive evidence, yay or nay, for the asymptomatic ones in regard, because you brought up the good point, right? You don't want to have people the babies that are truly asymptomatic will have no outcome whatsoever by the time they reach adulthood, versus those, 10% of the asymptomatic or somewhere in that range that do come down with hearing loss. Are there any positive, or those trials are ongoing, is there any known data suggesting that that's a potential mechanism to prevent the hearing loss that occurs, as they develop from months to a few years, as opposed to the ones that develop hearing loss at birth?
So there's 2 ongoing trials. There's one. So I think you allude to a couple of issues. One is in terms of timing of treatment. So you have a child who has hearing loss at birth. That might be different from a child who's 3 years of age with delayed onset. Do both of those children benefit with antiviral therapy? So there's a toddler study. They just completed enrollment. They've enrolled 35 children. It's a UK-US study. They're going through the data analysis. So we're probably within the next 6 months or so, we'll start getting data on that one. In terms of the truly asymptomatic ones, the Kasky group is just starting that study. So that's actually, it's an observational study. So essentially all the kids who are found to be asymptomatic, so they don't have any signs or symptoms, they don't have any hearing loss, are going to be offered antiviral therapy. I don't remember the duration of therapy. I think it's 6 months. It's a longitudinal study. They're just starting that. It's probably going to take 3.5 years to enroll enough kids, and then it's going to take some time to get that data analyzed. So we are looking at that question. I think it's certainly controversial. If I have a child who's truly asymptomatic, I don't think I'm going to offer them antiviral unless maybe I put them in a clinical trial, because I just don't know if that's the right thing to do. So.
That gets at the heart of what Soren has talked about in a number of these meetings about universal screening versus targeted. Obviously, it ends up with discussions, as you just pointed out, as to the value. Because if it's a targeted screening with no hearing loss, it makes sense. It's the question of value to universal screening for CMV as a whole, whether we catch those percent, and then, like you said, whether there's a positive outcome in those children, and if not, then, you know, it's a dollar value. And I know that always comes up. It's always an interesting conversation when we have these roundtable discussions about that.
I mean, I certainly have some of the most challenging situations are families who are asymptomatic, and a lot of those families don't come back. Right. So they're lost to follow-up. But then I know families who really appreciate that information, and they do come back regularly. I mean, what is your thought on that as a parent? Would you have wanted to know if your child was asymptomatic? Would you have wanted to have that information, or would you would have wanted to know that, right? I think most parents would want to know that information. So.
Yeah, again, Mark, I know, talked about that at the meeting, and he said most do, so that was good to hear. He said, but occasionally there are some that tell him, please don't ever talk to me again, and they walk out the door.
I think they appreciate the information, and I think then at least it's in the parents' hands, right? They can make the decision in terms of whether they feel they want to continue on with this or whether they want to not. But at least they have that information. So it's when they don't have the information, right? That's really hard on everybody. So, well, great questions, guys. Really appreciate your attention. So,
all right. Well, thank you again.